So once again, thank you organizers, thank you ESI for giving me the opportunity, and my dear colleagues for being available today. So today we will be having a discussion. I will be given a topic of approach to precocious or early puberty. And this is a topic which is focused on the theme of healthy hormones and women endocrinology. So this will be catering to the pediatrics, gynecology, as well as endocrinology, or even a general physician who can also see these patients in the community. So this contents in the next 20-25 minutes, I will be discussing on the normal puberty, definition of the precocious puberty, etiology of early puberty. I will give you a stepwise approach and when to investigate, the initial workup and identification of cause, and finally, before summarizing, when to take decision and how it will be important to do it. So coming to puberty, puberty is increase in the pulsatile secretion of GnRH, a gonadotropin-releasing hormone. Early in puberty, in females, estradiol stimulates the breast development and growth of the skeleton. This leads to the pubertal growth acceleration. As you can see later on, there is an interplay between various hormones. I'll just take the pointer. Yeah. There are interplay of various hormones that make sure that the pituitary secretion of LH-FSH and secretion of estradiol is coordinated. And finally, the ovarian follicles also get stimulated and finally lead to the ovulation and menstrual cycle. So it's a stepwise systematic onset of this physiology. And we can see ultimately the skeletal maturation induced by estradiol leads to fusion of the growth plates and cessation of growth. That is why usually the girls will have a lesser height than the male counterparts. So this is the summary which I have taken from up to date. This is a very good atlas for the same. So coming to a case scenario, this I had encountered about 3 months ago. She's a 4-year, 9-month girl, and the date of birth is very important to capture. And the mother noticed blood-soaked undergarments suggestive of vaginal bleeding. It was 2 times it happened, and she had come. So its breastbudding was also started, and it was increasing in size in bilateral. And when we measure, it was coming to Tanner stage 3, becoming taller than the elder brother. This is the wonder, this thing, because initially they thought it was good. But the last 6 months, they observed that the elder brother, who is only 1 year elder to her, she has crossed that person. Previously, it was not so. And present height when she came was 126 centimeter. And in general, looking itself, we can see the 50th centile is coming to 115.5 centimeters. So it's more than 10 centimeters than the expected for that. And she also had, when an examination, stage 2 pubic hair and sparse axillary hair. So what is the problem in here? So the patient has been referred for diagnostic evaluation, and by definition, sex hormone production or exposure occurring earlier than the norms for gender and racial or ethnic background. This is the complete definition of precocious puberty. And in textbook, we definitely have to have a norms. So that is why appearance of any sexual characteristics at an age earlier than the established normal standards for children of the same gender and race, and clinically useful would be before the age of 8 years in girls or 9 years in boys. Of course, racial differences are there, which I will allude to in the next coming slides. So what is this topic important? Because precocious puberty or early puberty is more common in girls than boys. This is the ratio is 3.5:1. And for the postgraduate students, very important to know that there is a first registry established called Danish registry in Denmark, which had nearly 20 years of patients follow-up, estimated that this percentage was 0.2% of the girls in that population with 0.05% of boys only. And that is the annual incidence over the 8-year period also comes approximately 10 to 15-fold lower in the boys. But in India, the prevalence is unknown, and relatively it's because of the awareness as well. Coming to Tanner staging, any person who has worked in an endocrine clinic will be familiar with this. But for the general practicing pediatricians or the gynecologists, we should also remember that this is a staging of puberty, and it describes the male and female genitalia. For the female, you can just see the stages. So this girl comes in the stage 3, which comes that continued enlargement of both the breast and areola without the separation of their contours. And you can see that as the time goes, it gets matured. So breastbedding, then later on getting maturer, and we can see ultimately the adult contour of breast is established. So it's a synchronized manner in which it happens. Even the pubic hair also darkening and further spreading to the suprapubic area and later to the medial thigh. So examination is very important, and palpation is also maybe required in some cases in the breast. And you can see inspection of the vaginal mucosa is a reliable indicator of estrogenic status because red glistening mucosa suggests a pre-pubertal stage, and pale mucosa indicates the exposure to estrogen. So I had alluded to sequence of puberty. What is sequence? It is actually a predictable sequence, and it's a progressive event, and we can see that is a reactivation of the hypothalamo-pituitary gonadal axis. Initial phase after birth, the gonad cessation is there. There is a small phase called mini puberty as well. And after that, the final puberty period, that you can see that the first thing to happen would be the height spurt, and closely followed by the breast budding, and then gain the pubic hair. So the height spurt is the one usually we are missing, and the earliest sign, which is actually clinical practice recognized, is the thilarchy. But of course, the literature says that we should watch for the height velocity also whenever you have a health records. On an average, the menarche occurs at 12.5 years in the US Caucasian girls, and at a later age and earlier age in the African American girls. So further, there is also a height velocity also, and median time for the African American girls is also lesser, earlier than the Caucasian counterparts. And this is the average age of the puberty, and the height spurt. It is actually taken from the Bansali, that is Anil Bansali's clinical rounds, and it's actually a very clinically relevant topic because it's from experience only sir has written these topics. This is a height velocity peaking around 12 to 12.14, that is the years of age. Just for the screen, we can just see this. So the upward crossing of the height centile contributes to the paradox of a tall stature in childhood, but ultimately a short adult height. So what about the pathophysiology of this? So kisspeptin is the one which is the gatekeeper to puberty, and the maturation of the HPXC axis is causing profound physical, sexual, and emotional changes, ultimately transforming a girl into a woman. So KIS1 mRNA expressing neurons from the arcuate nucleus and the antroventral periventricular nucleus makes synaptic contact with the GnRH neurons that is in the preoptic area, ultimately stimulated to secrete GnRH into portal circulation, releasing the LH and FSH. This is the pulse. This is the phase in which the kisspeptin, the action occurs. Once the matured adult, the pulsatile frequency is gone, and you can see sequences more frequent. So this is the study which I had told. This is a PROS study, PROS. This is a large section of cross-section from the 17,000 American girls between the age of 3 to 12 years. And the Lawson-Wilkins Pediatric Society initially suggested that the precocious puberty definition should be lowered to 7 years in white girls and 6 years in African American girls. But because it is only done by visual examination and there was no dissociation because thilarchy without change in menarche was happening, that is why later on it was dropped. And the studies further showed that decreasing age of evaluation will result to underdiagnosis of organic cause. That means that we will have more of idiopathic normal variant of patients having normal puberty than that is a true organic causes. That is why, despite limitation of the available data, the cutoffs have still been kept as 8 years in girls and 9 years in boys. So there is a trend towards puberty at earlier age. Dr. Usha Sriram madam had already pointed out there is improved nutrition, better quality of life. There is also a role for environmental endocrine disruptors. And there is the paradox of Barter hypothesis, in which the low birth weight followed by rapid gain of weight leads also to the intrauterine increased childhood obesity. Another point is that there are better control of infections because infections get controlled better. There is not talking about antibiotics, but generally the hygiene is improving. That is why there is an increased chance of puberty at the earlier age. There is also a role for genetic influences like kisspeptin mutations as well. So general hypothesis for the postgraduate in endocrinology, you can remember the term called Frisch-Revel hypothesis. The critical weight of 47.8 is what the menarche is triggered. This is proven through a long-term cross-sectional study. So this is an interesting article I just alluded to when preparation of the slides. It was published in Italian Journal of Pediatrics. There was an increased incidence of precocious and accelerated puberty in females during and after the lockdown. And this is actually a paradox because we don't know the previous data. So increased incidence was actually contributed with a more frequent examination. We can see that the triggers of environmental factors, the children are actually confined indoors, enhanced use of electronic devices. So there is a background radiation also. So there are very hypotheses mentioned. The population of central precocious puberty was also newly diagnosed. So this is the thing. Even the previous diagnosed people also faster progressed also with therapy as well. So on record, historically, the youngest mother on record, we want to definitely avoid this in our practice. But this is a population, this is the first on record that puberty at 8 months and actually gave birth at the age of 5 years. This is very historical description, now not a very important thing as well. So I will just, in gist, I will tell you the basic approach. The first one, as I told you, we just have to see when common sense whether it is a symptom due to actual puberty or something else. Second, it is if it on we have to point whether it's physiological or pathological. And once we identified it, then you have to go for whether it is isosexual, that is the same sex, the same characteristics, or heterosexual characteristics. Or the previous speaker also told about DSD. Is it a DSD which was missed earlier? That can also happen. And finally, once you have diagnosed, it can even be a peripheral precocious or true precocious puberty. And finally, the etiology. So it is not directly going for radiology. It requires clinical examination, history taking, and lot of methodical testing as well. For simple understanding, isosexual precocious puberty means that premature development of sexual characteristics concordant with the chromosomal and gonadal sex. That means thilarchy in the and menarche in girls and gonadarchy in boys. So it can may occur with or without premature activation of the hypothalamic pituitary gonadal axis. Heterosexual means there is a premature development of sexual characteristics of the opposite gender. That is clitoromegaly in girls and gynecomastia in boys. So it is always independent of the reactivation of HPG axis. And the point to note is that appearance of pubic hair does not distinguish between the isosexual and heterosexual precocity. History taking, we should definitely meticulously capture the breast development, the duration, the type of breast development, whether it is painful or painless, discharges there, progression, treatment and impact, and how it was noticed, whether it was chance or whether some other symptoms were there, tender or not. Fine, second menses, the age of the first bleed, how it was noticed, and this is important, temporal relation to the breast development, whether there is an antecedent or precedent to that. And you can see the quantity of blood loss, number of pads is very significant because the child may not be knowing. And the last date of menstrual period, how many bleeds till date, and how the treatment or improvement has happened. Pubic hair, again, examination is required. The child may not be aware. The age of onset, duration, how it was noticed, and relation to the breast development and menses, and progression, because this can happen half a sudden peripheral precautions. So this is why we have to systematically ask these questions in exam practice. Another thing is adrenarche, the oily secretions can happen. The body odor can also be different in this period as well. Finally, the family history, any similar complaints in the family, the age of the menarche of the mother, and the father's onset of puberty. They may not remember, but still a rough idea is required. And this is very difficult to capture. Exposure to chemicals, the sprays, the oil, tea tree oil, so many descriptions for improving the appearance. They are using so many chemicals. Even eating objects and also have these chemicals as well. So when you distinguish between false puberty, you should also remember that there is a concept called accelerated puberty. The children have onset of puberty at normal age, but rapid progression. But by definition, they don't have precocious puberty, and they require meriting only because we have to rule out causes like CNS lesions, adrenal and ovarian causes like PCOS, which are occurred after onset of puberty. So when to investigate? In boys I'm just leaving out, but see the girls, breast budding, labial folds, the color and pubic hair, the menarche onset, and the ultrasound evidence of uterine length more than 3.5 centimeter, volume, ovarian volume, and both gender. Advanced bone age is one of the things we have to investigate the signs. And the growth spurt, very important clue because pediatricians in office care practice keep growth chart in every visit. So identifying the growth spurt is very important, as well as careful history taking regarding the body changes. Why we are treating this is to prevent deleterious effect on the growth, reproduction, and ultimately the behavior of the child as well. So how to classify? So the practical approach, central precocious puberty is always isosexual. Peripheral is maybe isosexual or heterosexual. Central will normally follow the sequence, whereas peripheral may or may not follow the sequence. This is a common sense approach in practical practice. And classifying central precocious are gonadotropin dependent, and among them most commonly it's idiopathic. But when you identify an organic cause, it can be hypothalamic hamartoma, CNS infections, CNS surgery, radiation trauma, craniopharyngioma, other lesions, and secondary activation in CAH. CAH usually is a peripheral precocious puberty, gonadotropin independent. It can also happen in other conditions like adrenal adenoma, carcinoma, and McCune-Albright syndrome, as well as gonadal tubers. Benign conditions, physiological, they include premature thilarchy, premature adrenarchy, benign prepubertal vaginal bleeding, and non-progressive central puberty. So gender-based difference again is here. In gonadotropin dependent, there is a ratio of 5:1. In GIPP, it is 2.5:1. Again, this is for the DM postgraduates or even the practicing endocrinologists who may also know. 70% of girls with GDPP have idiopathic precocious puberty, whereas 75% of boys have a CNS pathology. That is why boys, definitely we have to go for CNS screening earlier. Etiology is remarkably different because in GIPP also, the McCune-Albright and ovarian cyst is a very common, very important cause in the female counterpart. Indian data from PGH Chandigarh had reported that 20% of girls had an organic pathology for the gonadotropin dependent puberty. So benign variants, just to touch on this, really important that it can occur within this 6 to 8 years of age. It may occur earlier as well. It is benign. It is only having slightly accelerated growth and advanced maturation. And there is only evidence of premature adrenarchy without activation of the axis. It is to exclude CAH and adrenal secretin and CPP. 45% of premature precaution may progress to PCOS. Pubic hair of infancy, it is actually seen as a atypical location in mons in females and scrotum in males, resolves spontaneously before the age of 1 year. This is because of mini puberty, and you can see linear growth, everything is normal, and no long-term follow-up therapy available. And premature isolated menarche is also important because it is isolated vaginal bleeding without evidence of any pubertal signs. It is a predominant FSH secretion. Just rule out genital traumatic injuries, neoplasm infection, very important to rule out foreign bodies and sexual abuse. This is important that they are normal prepubertal range of the hormone levels, just to require follow-up to normal onset of puberty. Premature thilarchy, again common in girls between infancy and age of 3. It is non-progressive. It doesn't exceed stage 3. No other signs of advanced puberty, regresses with time, and the size of ovary and uterine in the normal range, and no treatment is required. It actually, only some cases which start earlier than 2 years may progress to central precocious puberty. Premature adrenarche, to complete the list, very important because this may be an early sign of metabolic syndrome or polycystic ovarian syndrome, and is increase in adrenal androgens. It can associate with hyperinsulinism, dyslipidemia, and there is a history of family members obesity and diabetes and low birth weight in the child. So initial workup, oxology, previous records, very important. Next comes the X-ray left hand for bone age. Then comes to thyroid profile, and then go for the ultrasound pelvis and LHFSH estradiol. This is the basic first parameter we usually screen. Once we do it, then go for advanced imaging, then simulated LH studies and sex steroids if required in genuine cases. And I told you MRI pituitary if in less than 6 years, or CT abdomen pelvis in the specific for peripheral causes. So MRI being done to search for tumor or hematoma, obtain high resolution study focusing on the hypothalamic pituitary area. For healthy girls aged 6 to 8 years without signs of symptoms, only a likelihood of finding 2% of chance. Younger the child is CPP, larger chance of finding a CNS pathology. And pelvic ultrasound scan, I will spend 1 minute on this. In a girl less than 8 years of age, you mentioned the length of 3.5 centimeter, volume of more than 2 ml, ovarian volume of 2.8 ml, and the presence of endometrial echo is highly specific but less sensitive. They are evidence of estrogen exposure and denote the onset of puberty, but does not distinguish between the other causes as well. This is just to show you, this I have taken from the Bansali doctors, Dr. Bansali sir's clinical rounds in endocrinology, just to show you the proportions are varying and the shape of the uterus is also varying. So in a nutshell, breast development more than B2 less than age of 8 years, or menarche less than 9 years. First, exclude primary hypothyroidism, then go for stimulated or a baseline LH estradiol test. Then once LH is increased, estradiol is increased, definitely evidence of a gonadotropin dependent cause, go for MRI imaging of the sella. If LH is decreased with estradiol increase, shows a peripheral causes. Just rule out ovarian cyst or tumor, McCune-Albright syndrome, exogenous causes. Decreased LH with decreased estradiol is benign causes. Back to the case. So the case was, the girl was followed up, and we can see the height was more than 97 centile. The weight is also in the middle range. The bone age comes to advanced, that is 11 years, 4 months. The values are captured. TSH is normal, and you can see LH is mildly elevated. And you can see for that age group FSH is also high. And you can see estradiol is coming to higher range. Normal value is less than 10. Similarly, LH done was 8.8 MIU per liter. uterus size denotes that there is a definite evidence of a cause of precocious puberty. MRI evidence, no cyst or pituitary lesion or hematoma. So where are we? So definitely ultrasound is one thing which helped us. The increased ovarian volume is the best index for diagnosis. The best discriminating index is the uterine length. The follicle size more than 9 millimeter would have suggested a gonadotropin independent, but multiple cysts, 6 or more, suggest a gonadotropin dependent, and even a single cyst is feature of a gonadotropin dependent. So the concise approach would be systematically capturing the details. When you have a following in a sequence, definitely it will be a central. And if it is a rapid rate of progression, we should worry. And in female, when you have 3 years or older, definitely normal sequence and no other signs, definitely imaging is not necessary. So the concept of Gns Stimulation Test, it is because pituitary-driven puberty is responsive to pulsatile LHRH. We can take a 0-hour value, baseline value of FSH and LH, and leuprolide injection is given 0.5 ml, and 4 hours. In some centers, 1 hour is also done. LH and FSH is done, and 24-hour value of estradiol. Onset of puberty diagnosed if the 4-hour LH value is more than 5 or even 8 in some centers, or a 3-fold increase. 24 estradiol more than 10 picogram per ml. So cutoffs again taken from the clinical rounds of endocrinology by Dr. Bansali. This is the cutoffs mentioned in PGI manual as well. We can see this is the cutoff sensitivity and specificity mentioned. And leuprolide simulation test that if it is more than 5, 100% specific, but 78% sensitive. So this is a summary of the approach. Central precocious, age will be close to physiological age, peripheral will be early childhood, isosexual mostly in central always, and it can be different in the peripheral precocious. Progression is consonant in central, whereas it is discordant in peripheral, and growth spurt is seen in both, but you can see advanced bone age is seen in both of this. And you can see reduced bone age is seen in only one condition is called hypothyroidism or von Willebrand syndrome. Treatment of central would be GnRH analogs, and treatment in peripheral would be tumor excision, and in CAH will be steroids. And benign variants definitely merits only observation. Just see that they are not progressing as well. Goals of management definitely to attain normal height, prevent emotional psychological disorders, and regression of the sexual characteristics. This is the picture of all the different types of central precocious puberty we have come across. This is a spectrum I mentioned in PGI, the analyzed records. We can just go through it in your leisure time. It's published last year. And this is also, this is from PGI again, published in PGI, it is a Panbrick-Gunbach syndrome, published by Ashurutho et al. This is because long-standing untreated hypothyroidism leading to lack of specificity in feedback mechanism, leading to overproduction of multiple hormones. TSH interact the FSH to stimulate the adenine cyclase activity. McCune-Albright syndrome, to complete the list, it is autonomous functioning ovaries, and ovarian cyst can be mistaken for tumors and lead to unnecessary oophorectomy. It requires treatment with anti-estrogens or aromatase inhibitors, and the triad of peripheral precocious puberty, irregular cafe-au-lait macules, skin pigmentation, and fibrous dysplasia of bone. And you should always consider in DD when patients have recurrent follicle cyst formation. This is the summary of all the conditions which I have mentioned. Just to show you the ovarian tumor resection can itself be a cure for the independent females. Genetics, we have always to remember that there are many genetic mutations associated, like kispeptin gene, MRKN3, DLK1. Williams has mentioned all these. To remember that pubertal timing is all these genes, but there are also variants in the general population which requires genome-wide association studies. So finally, in a nutshell, again, are symptoms due to puberty or something else? Physiological, pathological, isosexual, heterosexual, is a DST missed earlier, and finally, etiology. So the sequence is the one which is a one catchy thing. Then hormone concentration, don't rely on the chart which the lab provides you. Go by the protocols. And when to treat and why to treat, because parents' presence is a very must thing. Recognize the ability to cope with sexual changes. Remember that metabolic sequelae is very common, and increased sexual activity as the child is very much noted. And if you are seen, if height deficit is there, there is a range of 8 to 12 centimeters in girls. So very significant. That is why we should treat them and to get good results. Just a word about treatment. GnRH analogs are used. They are a highly specific physiological pharmacological clamp on gonadotropin. They are also called reversible medical gonadectomy. Means we initial phase is pulsatile, we are abolishing it. Ultimately, when giving in sequence, it becomes continuous action. That means the reduction of LH is there. And finally, we have to get treatment results. Various regimens are available and various preparations are also in the market. So summary points, fundamental 6 steps have to be remembered. Precocious puberty is a holistic diagnosis. It is not a biochemical diagnosis alone. Practical approach, multiple factors to consider. Evaluation of precocity, growth chart, Tanner, and bone age are as important as the hormonal profile. A beautiful summary is taken from a mini review published by Amini Madam's group from AIMS. Thank you for the kind listening, and thank you, organizers, for giving opportunity. I will be open to questions. You can follow me on Twitter and also approach me on the email as well. Thank you.